Now, let's talk about this. We're going to head up into general medicine right now. And what are we looking at with this card right here in our Brilliant Board Review and CME? What is this card? This is our ACE card. Now, what are we talking about? ACE, okay? Adverse childhood events. And I want you to start thinking about this in your patients. You may even be thinking about it in your family members, your friends, maybe even yourself. And we really don't discuss this enough in medicine, of people who receive physical abuse, sexual violence, emotional abuse, or they've witnessed violence in their lifetime, parental separation or divorce, substance use in the home, mental health problems in the home, incarcerated house member, food insecurity, and homelessness. Now, at least about 64% of U.S. adults have reported experiencing at least one adverse childhood event. Just think about this. One adverse childhood event has been experienced. 70% of adults have reported 4 or more ACEs. So I want you to think of adverse childhood events as being maybe one of the reasons why you have these patients in your clinic, in your hospital, is because they've suffered these events in the past, and it's made them have health problems. ACEs are linked to chronic health conditions such as asthma, stroke, and obesity. We're still trying to figure out why. ACEs are linked to mental health issues like depression and anxiety. ACEs are linked to substance misuse, risky behaviors like smoking and heavy drinking, and lower educational attainment. We know all these things cause a decreased lifespan and increased mortality. Think about it in your lives. Have you experienced an ACE? How has this affected you? Now translate that over to your patients whose lives may have been even worse, who grew up in poverty and grew up in a household that was not conducive to learning or not conducive to health. So start thinking about ACEs when we're taking care of our patients. Is this the underlying cause of the condition that they have, that you are seeing and presenting in the hospital, on the wards, in the ICU, or in your clinic? Well, let's bust another dogma. Osteoarthritis. Now, that's from repeated injury, right? If you go in your textbook, it's repeated injury. No, it's not. It's a chronic low-grade inflammation. Now, is it possible they had an injury first and then we have an inflammatory response second? It's possible. That may be the correct answer, is that it's a combination of kind of both. So or overuse injury combined with inflammation. So we're seeing inflammatory markers that we didn't really think were present. IL-6. This is starting to get familiar with IL-6. You remember that thing, COVID? IL-6 was really elevated in that too. Inflammatory markers, just start thinking about this. TNF-alpha, we see a lot of this. Where do we see this? Rheumatoid arthritis, right? IL-1 beta. So these are things that we need to change our mindset, and we'll talk some of these. So it appears that yes, there is wearing down. Now, I want you to also do is to think of a terminology. And if you really talk to the people who specialize in osteoarthritis, they want you to get away from this terminology, bone on bone, okay? Where you're saying, you got bone on bone, that's why you have that pain. Get away from that, because it's not truly bone on bone. The patients have worn out cartilage. So when you say bone on bone, that gives that patient a license not to exercise. Of course, who's gonna exercise if they have bone on bone? When they really have worn out cartilage, and what we can do is teach them through either our physical therapy colleagues, YouTube videos, or just slowly working to get more levels of fitness, building the strength of the muscles around there. So what we're trying to do is build the muscles around the joint so we take stress off the joints. But if you say bone on bone, and I know you've been told, oh, it's bone on bone, or maybe a provider has said to your family, oh, they got bone on bone wear. Maybe they've told you that. Let's talk more about the more correct term, and so it's not as limiting. Say there's wear on the cartilage. Just changing our terminology can be a little bit, can change the way physicians view, how providers, physicians, and patients view a disease. We need to change our terminology and just those little tweaks. How about in this, when you're talking to your patients, instead of saying, do you want to make your loved one DNR? Do you want to be DNR? And that seems like we're taking away something. Do not resuscitate. For someone who has had nothing in their life, they may want this to say, I've had nothing in my life, and now somebody wants to take away something from me at the end of my life. Instead of saying, do not resuscitate, how about we can change the terminology to, how about we allow a natural death? Because when we die naturally, we're not getting chest compressions. We're not intubated and put on a ventilator. Maybe changing or tweaking our terminology just a little bit may open up some venues to have discussions with our patients. Not saying that's going to change a patient's mentality, but it gives us a different venue of discussion instead of do not. And when you have a negative connotation, you're going to enter is do not resuscitate. People may shut down from you automatically instead of saying, would you like us to allow a natural death? All right, let's talk about duloxetine, using this for osteoarthritis. Now, improves several chronic pain conditions, diabetic neuropathy, fibromyalgia, chronic lower back pain, and osteoarthritis. Because guess what? Acetaminophen does not work well. The studies have proven that. It does not work well. And NSAIDs, they have huge lists of side effects. And usually our patients are older. And what do we have to worry about with NSAIDs? We discussed this before. Increasing risk of edema, increasing risk of heart failure. These are things that we really, and kidney injury. As we get older, our kidneys don't work as well. And our heart doesn't work as well as we get older. So we need to do things to avoid causing an injury. If you're taking NSAIDs every day, there's an increased risk for kidney injury and heart failure. All right, let's go with a clinical case. Now, this is an interesting one, and this is a true story. This is a 47-year-old female with past medical history of just peripheral neuropathy. And it's idiopathic. Us idiot providers don't know why she has peripheral neuropathy, but she does. No diabetes, no other known inflammatory conditions. And she's noted to have nausea, vomiting, diarrhea. She had a simple flu bug. She had norovirus. She went on a cruise and got norovirus. Very simple, right? Very simple. You may have had this happen to yourself. You may have had it happen to your patients, family members, loved ones. And nausea, vomiting, or diarrhea. So what happens? Is that what? Does our kidney function get better or worse when we have nausea, vomiting, and diarrhea? Well, first of all, she has decreased intake. She's not taking or eating things. So decreased intake, and then she's having increased output because of this increased nausea, vomiting, and diarrhea. And she becomes obtunded and intubated. Why? Well, first of all, what is given out like candy for peripheral neuropathy? Not saying it's bad, just telling you what's going on, and you know it too, and you may prescribe it. You may have seen your family, loved ones, and or you may be taking it yourself. What do we get? Gabapentin, right? Everybody gets gabapentin. Everybody has to get gabapentin before they die, right? And this young lady happened to have a very high dose. Hers was 3,600, which is the max. She was taking 1,200 3 times a day. And in fact, when she was becoming more obtunded, what happened to her is the family was like, they knew how important this medication was to her. They'd wake her up a little bit. She's drowsy, sleeping on the couch, wake her up and give her a dose of gabapentin. And put a little water. She may choke a little bit because she wasn't doing so well. And she gets what? She gets more obtunded. Because guess what? It's that bucket theory already. So you have the bucket, and you're putting the gabapentin in the bucket, but you don't have a way of, there's no hole at the bottom of the bucket like there normally is. The problem is her kidney function got worse because she had nausea, vomiting, diarrhea, because she went on an amazing cruise and she didn't go on the famous poop cruise, but she went on one of those cruises where she got bad norovirus, and she could not excrete the gabapentin. It sat in her system. The kidneys weren't working well, so she wasn't able to excrete it. She's taking a dose, and it's sitting there, and she has a super therapeutic level. So she comes to the hospital, and she's obtunded, and she gets intubated, okay? She was intubated with no medications. That's how obtunded she was. All the rest of the imaging was negative. She didn't have a stroke. She didn't have a vessel occlusion. She didn't have a seizure, because this was looked for in long-term EEG. She had what? She had gabapentin toxicity. And guess what? It can't be dialyzed out. So what do you have to do? Just wait it out. She waited it out on the ventilator. It took 5 days till her kidney function caught up and she was able to excrete the gabapentin. So I know gabapentin's the greatest thing in the world, and I know that people love giving it, but it has side effects. It has a lot of side effects. And maybe not work as well as we think it does. Gabapentinoids and COPD. This is another discussion. So what is gabapentinoids? What are gabapentin? What is the main thing it's for? Remember, it's a drug for epilepsy. It was a drug for epilepsy, and then kind of on the aftermarket, it was kind of discussed as it may help with neuropathic pain. Well, does it? So, but it does do is increase the risk of severe exacerbations for COPD. And guess what? There's new literature that asthma does the same thing, increases. Now, it causes respiratory suppression, so yes. So in 2022, there's 40 million scripts of gabapentin in the US. 40 million. So guess what? You're going to have patients that have COPD and gabapentinoids, and guess what? It can affect the way they breathe. So there's also residual confounding in this study. The study was good, but it wasn't perfect. But it includes, there was lack of smoking information on this. So that can affect the way that we're having severe expirations too. So it can affect the way that we're having severe exacerbations. The study had a confounding factor as it did not include the smoking information. Follow-up studies have also concluded and agreed with this statement. And then there's also a study coming out on asthma that gabapentin has affected the way people are breathing in asthma. Now gabapentinoids, let's go with some of the side effects. Dizziness, drowsiness, can cause peripheral edema. Did you know that? In 8% of the cases of people taking gabapentinoids can get peripheral edema. Gait disturbance and ataxia. What are we worried about with ataxia? What are we worried? Are the patients going to be older taking gabapentin? Yes, they are. What happens when we fall and we're older and we break a hip? Things do not go well for us. That can be a life-ending maneuver. Another story on gabapentinoids, giving preoperative gabapentin among older adults after major surgery. So the thought process was, if we give the gabapentin, are we going to reduce pain? So what happened? So patients 65 and older underwent major surgery within 7 days of hospital admission, didn't use gabapentin before surgery. Exposure, gabapentin use within 2 days after surgery. Main outcomes were delirium, secondary was new antipsychotic use, pneumonia, and in-hospital death between the pre and post-operative day 3 and hospital discharge. This is what they're looking at. After propensity score matching, so this is where they're getting data from the EMR and using special formulas. You're going to see a lot more of this because we see a lot more propensity matching studies because we have all this data from this EMR, so we're inputting in. Gabapentin users and non-users. The mean age was 74.5 and 62.7% were women. Non-users versus users, okay? Non-users, delirium 2.6 versus users 3.4. New antipsychotic use, about the same. Aspiration, pneumonia, no difference. So there's no difference in hospital death. Increasing the gabapentin dose progressively increased the risk of delirium. Now this is a game changer. We'll talk more about delirium, but once patients get delirium, what happens? They have increased risk of mortality. We can see physical changes on an MRI for delirium. Risk of delirium among gabapentin users increases subgroups with high comorbidities and chronic kidney disease, which makes sense. What makes sense is because chronic kidney disease, they're going to have more trouble and decreased ability in excreting gabapentin. It's going to be harder to pee out the gabapentin. All right, now let's talk about medications that can cause edema. Thiazide. What are examples of these? You don't see these used too much for diabetes much anymore. Well, pioglitazone and rosiglitazone, you have to have a special waiver to use. Calcium channel blockers, well, these are used often. So if a calcium channel blocker causes edema, peripheral edema, one of the side effects, you need to use an ACE or an ARB to kind of mitigate that. So then you're adding to the amount of medications. We know as we add more medications to patients' lists, they have a decreased chance of taking the medications. They get tired of it. They're like, what is these providers doing? Why do we have so many medications and I'm going to stop taking it? You also get is after a while they can't afford it. So if you're using a calcium channel blocker, the treatment, and they get peripheral edema, the treatment can be given ACE or an ARB. NSAIDs, as we talked before, one of the side effects, heart failure, chronic kidney injury, or acute kidney injury, chronic kidney disease, and it can also cause peripheral edema. Gabapentinoids, we talked about this. Gabapentinoids, vasodilatory, and can decrease smooth muscle tone. Oral contraceptives can, and corticosteroids. Now, as we talk more about inflammatory response in knee osteoarthritis or osteoarthritis in general, we can talk about using anti-inflammatories such as methotrexate. So this is going to change. Now it's going to take time for the textbooks and for knowledge to get caught up. Is osteoarthritis, at least think of it as both in an injury, an overuse injury combined with inflammation. We don't have enough proof to say it's inflammation alone. Osteoarthritis has an inflammatory component, okay? Very important. Chronic pain reduces the quality of life. If it's hard to get out of your chair, are you going to get out of your chair? If it costs you pain to walk, to go to the grocery store, to go to the pharmacy, you're going to be less likely to do it. Remember, decreased activity has what? Decreased activity causes us to have decreased level of fitness. In this study, the patients got methotrexate once weekly. They either got 10 to 25 milligram dose versus placebo. Significant reduction in pain. Significant reduction in pain. Now, this was a double-blind study. It was in the UK and Canada, just so you know. It was about 207 patients, and they had radiographic evidence of osteoarthritis and knee pain for 3 months with inadequate response to current medications. Now, what's the side effects? The side effects of the methotrexate. About 20 to 65% had nausea, vomiting, and he also had mouth ulcers, which is one of the side effects of methotrexate. Some had headaches, fatigue. They also call it methotrexate-induced neurofog. You need to take 1 milligram of folate daily, and you can also do is 5 milligrams once a week. You need to take the folic acid daily or once a week. Liver damage, 15 to 50% had elevations in liver damage, fibrosis, inflammatory disease of the lungs, and they had a drop in white blood count. And so it's not a perfect drug, but this is at least we're looking at osteoarthritis having an inflammatory component, because what we're using now doesn't work. Patients, there's so many side effects with going on long-term opioids. Acetaminophen does not work. NSAIDs have worked but have too many side effects. Duloxetine could be another option available for our patients. But let's look at the inflammatory portion of this. All right, we're going to a screening section for infectious disease. For chlamydia, one is a recommended do screening. Sexually active women age 24 and younger. Older women, older than 24 with risk factors. Not recommended in men. Gonorrhea, pregnant women, sexually active women with risk factors. Not recommended in men. The testing is not going to be as great, so less propensity for men to have it. Well, what happens is men, they present with symptoms faster than women, and that's why the testing is not recommended. So men usually present with symptoms faster than women, so that women can be more of a chance of an asymptomatic or less likely to have symptoms than men. Screening for infectious disease, HIV. Adults age 15 to 65. Anybody basically. Pregnant women. High-risk individuals. Hepatitis C. Now we have a cure. We have a cure for hepatitis C. So we need to test for it so that way we can take care of our patients. Because what happens is they can have debilitating liver injuries and require liver transplant. And we already know how there's so many limitations on liver transplants in our liver transplant system, and there's just not enough livers for the patients that need liver transplants. Asymptomatic adults and adolescents, and they recommend ages 18 to 79 years old. This testing, regular it could be once in a lifetime, or if you feel that the risk factors. Screening for infectious disease, for syphilis. Pregnant women and high-risk individuals. And you also may get, as your health department, your localized health department may warn that there's an outbreak and recommends testing, and it may give certain groups to recommend the testing for. TB, those with HIV in high-risk individuals. And usually the high risk means it's coming from an area's endemic for TB, or maybe their relatives have had exposure to TB or TB themselves. Screening for colorectal cancer. Screening for colorectal cancer started at age 45. I know it was 50 before. It's being lowered because the fact is we're seeing younger people get colorectal cancer. And this is a disease that we can get early in a treatment pattern and save lives, and continue to age 75 years. Stool-based screening tests and intervals as follows. A guaiac fecal occult blood test every year. Fecal the FIT test, which is the fecal immunochemical testing every year. These are getting better. There's still not a sweet spot on these. The goal for the pharmacy companies is to have where this is the best test in the world, so that way you don't have to get the colonoscopies. Now remember, if you get this and it comes positive, you're going to have to get a colonoscopy. FIT DNA every 1 to 3 years. That is a different test, the FIT DNA, from the FIT test itself. The FIT DNA has the fecal immunochemical test. The FIT DNA has both the FIT and the DNA. Direct visualization screening tests and intervals as follows. This colonoscopy every 10 years. And we'll talk about intervals if a lesion is found. CT colonography every 5 years. And FlexSig every 5 years. Remember, the CT is not going to be as good as the direct visual. Flexible sigmoidoscopy with FIT, sigmoidoscopy every 10 years with FIT every year. So these are options. A lot of patients are not going to want to get the colonoscopy. It is, getting the bowel prep alone is a brutal battle for some patients to do. Some just will not do it. So there's other options that are coming available that hopefully will get patients more adherent to getting screening for themselves.